Good afternoon, and I'll start my presentation. And my topic for presentation is targeted therapy and Indian context. What I will do is that I'll try to present the targeted therapy in the context of lung cancer to understand how it has made a difference in our patients' management. So was the paper in JAMA, and what it suggested that in lung cancer, in 1,000 odd samples, if the target is there and if there's a targeted therapy given, it improves survival of the patient. And this is an example showing that yes, if you have a target, you have a targeted therapy, then there is a good response seen in CT scan, and which also gets translated in improved life or improved survival for these patients. We also took up this challenge at our own center, and we tried to see, can we develop targets that is a test to diagnose the target, which can be given to or which can be done by any patient coming to our hospital. So this test to EGFR mutation, that is one target in lung cancer, and the test was developed in-house, and as it was developed in-house, we were able to give this to our poor patient at the cost of ₹700. And that's the reason most of the patients at our hospital get the EGFR mutation testing done. As this test was done in majority of our patients to coming to the hospital, so initial 1,000 odd patient data we could analyze and find out what is the mutation rate in our population, which was 23%, where it is more common, like a non-smoker, adenocarcinoma, and female, and this suggested where we need to focus as far as targeted therapy is concerned. This data also help us in understanding what is the geographical distribution of EGFR mutation in India, and it appears across India in all the parts. The mutation rate remains similar, that is around 20 to 25% for lung cancer patients. If we see WHO website, Indians are categorized as Caucasians, and we wanted to see what is the mutation rate in our lung cancer patient as compared to Eastern Asian or Western population. And it appears the mutation rate in Indian population is in between Eastern Asian and Western population. That is around 25%, which is around 10 to 15% in USA, and around 40 to 50% in Eastern Asian population like Japan, Taiwan, or China. We also analyzed in this initial report what is the survival of these patients when they are given targeted therapy. And it appears if you have mutation positive patient, that is EGFR mutation positive patient, and they were given targeted therapy as compared to if it was given to mutation negative patient, the survival was better, 19 months versus around 10 months. There are various randomized trials which has been done till date, and we tried to compare our data, which was retrospective data. Does our overall survival matches with whatever has been there in the literature? And it appears that our survival for patients is similar in what is there in literature till now. So this was a challenge for us, that can we do a randomized trial to prove this concept that targeted therapy in a patient who has got a target does better as compared to chemotherapy which is given routinely. And this was a study done where we tried to get the best of the chemotherapy possible to compare with targeted therapy, that is Gefitinib, in this situation, which has never been compared with pemetrexed followed by pemetrexed maintenance in this population. Primary objective was progression-free survival. Secondary objective was overall survival, response rate, safety profile, and quality of life of the patients. This was the method. All the patients with EGFR positive patients were randomized between oral tablet versus IV chemotherapy, that was pemetrexed plus platinum, and after receiving the treatment, they were followed up subsequently during the follow-up duration. The sample size was calculated with expectation that 6 months progression-free survival is there for chemotherapy, and we expect it to improve by 50% with the power of 80% and 5% type 1 error. And we needed around 20 to 90 odd patients, with factoring in the dropout for these patients, to prove that we will have 50% improvement in progression-free survival with this therapy. This is the consort diagram for the result. We had 290 patients equally divided, and if we see the patient who discontinued treatment, majority of them, they discontinued because the treatment, patient progressed after the treatment being given to them, and subsequent follow-up of survival also was there. This is the baseline detail in our study, and what appears that they were well balanced in both the arms except gender, where male were more in chemotherapy arm as compared to targeted therapy arm. Coming to the response rate, and what we can see that almost 64% patient in Gefitinib arm they responded as compared to 45% patient in chemotherapy arm, again confirming that Gefitinib patient receiving Gefitinib with EGFR mutation, they had far more responses as compared to chemotherapy. We also analyzed the toxicity to see the tolerance for the therapy, and it appears that in different arms there was a different kind of side effect, like rash and loose motion was more common in Gefitinib arm, but anemia, neutropenia, thrombocytopenia, they were more common in patient receiving pemetrexed. This is the progression-free survival data, which was the primary endpoint, and if we see the hazard ratio, this is 1.5, suggesting that there was 50% chance, a relative risk of decreased risk of progression in the patients receiving Gefitinib as compared to patient receiving chemotherapy, and it met its primary endpoint with p-value being 0.001. This is the forest plot for the progression-free survival, and we can see that for all the subgroup, the progression-free survival was better in the patient receiving Gefitinib as compared to chemotherapy, except for performance status 2 patients. But what we see that in performance status 2 patient, the number of patients were very few to make an interpretation. We also have the overall survival data, and it appears that overall survival data in both the arms were similar, and this is primarily because of there was almost 70% crossover for the patient receiving one drug over the another. So what we can conclude with this study, that in a well designed randomized trial with 290 odd patients, Gefitinib was better as far as the progression-free survival is concerned as compared to chemotherapy in EGFR mutation positive patient. Overall survival was similar, but it is far better than what we see usually in the lung cancer patients, which is around 6 to 8 months, and that's primarily because of crossover, and that's the reason in both the arm survival remains similar. When we compare our data with what is there in the literature, what we can see that this was the patient in the trial was in good number. In fact, this is one of the large study, and if we see the data regarding PFS and overall survival, it is similar to what is there reported in the literature. In fact, this data will be presented in World Lung Congress 2017 in December. We also did some of the study to see what are the other mutations which is there and how they factor in as far as EGFR is concerned. People do wonder if you have a coexistence of two mutations, how the patient behaves. We did have 3 patients with KRAS mutation and EGFR mutation, and we had an opportunity to see if they respond to Gefitinib or not. What we observe here, that all the patients, they did respond to Gefitinib, suggesting that if you have EGFR and KRAS mutation coexisting, these patients may be given TKI where the chance of response is good. And this was tested by multiple methods to ensure that yes, when these 2 mutations were there, they were really present. We have also analyzed our data for doing mutation profiling in lung cancer patients. We have done in almost 400 odd patients. This is done in the collaboration of Dutt Lab at ACTRAC, and what we observe that almost more than 50% of the patients, they did have some or other mutations, but we can see the mutation profiling and the mutation type is different as compared to what we see in Caucasian population. We also analyzed our survival data in the patients receiving targeted therapy in this 400 odd patients, and what we see, it is similar to what is there in JAMA publication, that if you have a target and you are able to give effective targeted therapy, then survival is better for these patients as compared to patients receiving only chemotherapy. Because of doing this mutation analysis in significant number of patients, we also have data regarding uncommon mutation, especially in exon 20. And what we observed that in exon 20, majority of patients are not T790M in our population. They are mutations which are relatively uncommon, and it appears these uncommon mutations, they don't behave in a similar manner. And what we see here is the median survival varies from 2 months to 12 months, suggesting we need to understand these uncommon mutations further with more number of patients. Brain mets in EGFR mutation positive patient is a bit of an enigma, and what it appears that EGFR mutation positive patient may have more brain mets, and it also is not so well known that if they have a brain mets in EGFR mutation positive patient, how do they do? We have a chance to analyze this because of again having a large data set, and in fact this is the appears to be the largest data set analyzing the brain mets in the patient having EGFR mutation positive lung cancer. It appears that brain mets are more common in EGFR mutation positive patient as compared to patient not having EGFR mutation in lung cancer. We also had the chance to analyze the outcome of these patients, and it appears the patients, if they have a brain mets, they may do a bit worse as compared to the patient not having brain mets. P-value is not significant, but there is a trend towards the same. As far as the type of mutation is concerned, it again appears that exon 90 doing better as compared to exon 21. Again, this is similar to what is there in the literature. Liquid biopsy, it is important. We have tried to develop it, but I'm not going to discuss it here at this moment. But it appears liquid biopsy can be done in the patients, and correlation in our hand, concordance in our hand for tissue biopsy versus liquid biopsy in the patients are in the tune of 94%. This is an example of something if we do in the lab, how it can get translated immediately in our clinic. And here was a family where there were 3 family members having lung cancer, and when the mutation analysis was done, we found a mutation in HER2 domain, and these patients, out of 2 we were able to expose to HER2 inhibitor, and it appears that it was useful for the patient, and when they were exposed in 3rd line and beyond setting, they had a progression-free survival of more than 1 year in both this patient, suggesting that one can get effective treatment which can be implemented in the clinic if we have this genomic data available for them. ALK mutation in our population, that is from TMH, we do it routinely for our patients, and this is data for around 1200 patients. And what it appears that when we started with FISH, almost 5% patient they had ALK positivity by FISH. We subsequently started doing by IHC, but before we shifted to IHC, we had a chance to validate it, and when we validated it, it appears that either we do by FISH or IHC. The sensitivity is around 96%, specificity is 94.4%, and overall accuracy is 95.5% for IHC. And after subsequent to that, if we see concordance rate, it is again around 95%. And subsequent to that, we do ALK testing in our patient by IHC. And overall, it appears that once we have started doing this ALK test by IHC, then the positivity rate in our population has gone up to around 10%. We also had the chance to see the outcome of these patients once they have been given Crizotinib or they have not been given Crizotinib. And this was a data of around 100 odd patients, and almost 70% patient we are able to give Crizotinib. And this we want to emphasize with this slide, that we do all kind of work mobilizing our NGOs and trying to get drugs for the patients, and we have been able to give this drug, which is not so cheap, in almost 70% of the patient because of the hard work done by the social worker department. And when we analyze the data of the patient getting exposed to Crizotinib and the patient not getting exposed to Crizotinib in ALK positive patient, it appears that progression-free survival was better for patient who got Crizotinib as compared to who did not get Crizotinib in these patients. This is the overall survival data. And what it appears that median survival of these patients are 36 months, if the estimated 36 months if they received Crizotinib, as compared to around 10 months if they did not receive Crizotinib. Emphasizing that in the patients where you have mutations, they are a driver mutations, and there is an effective therapy for them. then these patients needs to be exposed to this therapy to ensure they have an optimum survival and they have optimal outcome. These are my collaborators, highlighting they're from ACTRAC, Medical Oncology Department, from my own department, Medical Oncology Molecular Lab, and the people from outside like MedGenome and Strand Life Sciences. I need to thank them for all the help they provided in getting many of this work done. Thank you so much, and I will be happy to take any question if there is.
So first question is from Salvi. What types of surgery are used to treat the lung cancer?
So for lung cancer, the surgery is either we do segmentectomy or lobectomy or pneumonectomy, and apart from that, one needs to remove the lymph nodes. Usually, the patient, if they can get treated, lobectomy is preferable. Segmentectomy is only done in patients who are not fit for lobectomy. Otherwise, preferably lobectomy. Pneumonectomy, the chances of on-table mortality is a bit higher, so pneumonectomy is avoided. But if lobectomy is not possible to treat with lobectomy, then pneumonectomy needs to be done.
Second question from Dr. Ajit. What are some of the cellular changes that lead to cancer?
So there are many. In fact, I wish we knew exactly. This is the only changes. Apart from the cell cycles, you can have apart from the cell cycles where there can be changes. You can have changes if you take structure-wise. You can have nucleus, which becomes bigger. You have chromatin, which is thicker. Nuclear and cytoplasmic ratio becoming bigger. Then I told about cell cycles. Then you have various pathways which can get disturbed. And what we understand, there are 6-7 pathways which finally drives the cell. So it can go wrong at multiple places in cell.
Next question is from JB Pani. Which method is preliminary used for detection of mutation in EGFR gene, whether it is TACMAN based RT-PCR assay or Sanger sequencing approach?
So all the method he mentioned, they can be used to test EGFR mutation testing, but most important is that they need to be validated in their own lab. Only catch is that, for example, what he said, ARMS, that is a kit available, one can use it. For all other, you may not necessarily get a kit, and that is you need to do yourself and ensure that it's a validated test in your own lab. But one can use any, so we can have ARMS, you can have other real-time PCR method, you can have Sanger sequencing, or you can have NGS. The only catch is here is that all others has got similar kind of sensitivity, except Sanger sequencing, where the sensitivity is low.
Next question from Dev Singh. At what stage of lung cancer treatment would you consider broad molecular profiling, diagnosis, or first-line progression?
It needs to be at the diagnosis. If we have not done, then we can do it when they progress, but preferably will be at the time of diagnosis. In a stage, in a palliative setting, that is an advanced cancer.
Next question from Nilanjana. What are the side effects of targeted cancer therapies?
So this depends upon which targeted therapy we are talking about. But if we talk about targeted therapy, which I just talked about in lung cancer, then if you take EGFR inhibitor, primarily there are 2 side effects, that is skin rash and diarrhea, but then there can be many other. And if we talk about ALK inhibitor, then it's primarily weakness, fatigue, nausea, vomiting, visual disturbances, and in ECG what we call is QTc prolongation, which can lead to arrhythmias. But again, I repeat, this is only for targeted therapy, which I talked about. There are many other targeted therapy, like works in renal cell cancer, works in many other settings, that side effect can be very different.
Next question from Supriya. What are the side effects of targeted cancer therapies?
So I will elaborate further on that. I talked about the side effect of targeted therapy, which I just talked in the lung cancer. But if you take, for example, renal cell cancer, then the targeted therapy is what we call sunitinib, pazopanib, sorafenib, everolimus, cabozantinib, and their hand-foot syndrome, hypertension, cardiac side effect, electrolyte abnormality, hypothyroidism. These are the side effects you can have. If we take breast cancer, where we use trastuzumab, then the cardiac side effects becomes very important. If we take head and neck cancer, where we use cetuximab or nimatuzumab, skin rash is pretty common, and electrolyte abnormality is pretty common. If you take everolimus, which is used in breast cancer and also in renal cell cancer, carcinoma, then the patient do develop fatigue, weakness, and hyperglycemia. So repeating that different targeted therapy will have a different side effect, and accordingly we need to adjust. Or if you take bevacizumab, which is again VEGF, we can have side effect of bleeding or hypertension.
Next question from Dhruv. Does a negative chest X-ray definitely mean a person doesn't have a lung cancer? Apart from this, what other tests can be done to detect the same?
So, so negative X-ray doesn't mean patient doesn't have a lung cancer. But key is that if you don't have a symptom, then you don't need to do an investigation, unless you do a scan as a part of screening. So if the patient is a smoker, it belongs to the and he is smoking for 30, his smoking rate is 30 pack years, and he's above 55 years of age, between 55 and 70 years, then scanning can be done to detect cancer. Otherwise, if there is no symptom, no scanning needs to be done.
Next question from Vishal. How can blood pressure drug boost effectiveness of lung cancer treatment?
So, blood pressure has got no relation with lung cancer treatment, unless there is a complication. So you can have you can give cancer chemotherapy, and after that patient can develop infection, and which can lead to decrease in the blood pressure. Otherwise, there is no direct correlation between the lung cancer therapy and blood pressure drop.
Next question from Dev Singh. Given that underlying genomic profile of the patient may change after targeted therapy, would you consider rebiopsy on progression for biomarker profiling?
So very important question, and I totally agree. I know that after giving therapy, the genomic profiling changes, and wherever we have effective treatment, one needs to do a repeat biopsy. And for example, if the patient has EGFR mutation, positive patient where we have given gefitinib or erlotinib or afatinib, and if they progress, one needs to do the repeat biopsy, because we have effective treatment subsequently in those settings. But for example, if the patient is ALK positive patient, mutations may change after giving crizotinib. But having said that, mutation-based therapy is not there. So that time doing mutation may not be of a good help, but it appears in future it is going to come in that situation also. But in many other settings we do it. And again, another setting is in breast cancer where it needs to be done. If you take in lymphoma, where we give CD20 based therapy against CD20, again we do it. So in certain situation where it makes a difference in the treatment, we need to do it, because therapy has to be available in that setting. You may have a different mutation, but therapy has to be there. If no therapy is there, in spite of change in mutation is happening, then we don't do the biopsy.
Next question from Muneet. How is genetic testing different from targeted therapy?
So targeted therapy is for a target, and genetic test is done to detect the target. So genetic test is only to test if the target is there or not. And targeted therapy, that is a treatment, can only be given once we do the test. So they are pretty different.
is there any chance of lung cancer in a person if he does not smoke?
Yes, there is a chance. So it is true that lung cancer happens more commonly in patient who smokes, but there is a small chance that non-smoker can also get lung cancer.
Next question. What is precision or personalized medicine?
So precision and personalized medicine means that individual patient, they are evaluated, and based on many data set, one decides that what kind of therapy is best for them. And one of the way is to do genomic testing and decide the therapy. But this is only one of the way to do it.
Question from Dave. Is chemotherapy anyways related to lung cancer treatment?
Chemotherapy, can you repeat the question?
The question is the chemotherapy anyways related to the treatment of lung cancer?
Yes. So today also, apart from 30% of the patient where you have mutations where it can be targeted and where we have a therapy for targets, other patient needs to be treated with chemotherapy, and chemotherapy adds life to the patient. It appears to be less effective than targeted therapy, but yes, when you don't have mutations, this is the best treatment possible.
Next question is from Amit. Why is knowing your mutation status is so important?
So if we know the mutations and if we have a targeted therapy for that mutations, the average life of the patient changes from 8 months to 4 years or 5 years if we have all the therapy available for these patients. And that's the reason we need to know.
Next question. What happens if the tumor of a patient is EGFR mutation positive?
So if the patient has got EGFR mutation positive, we need to look into it. It is a sensitive mutation or it is a resistant mutation for TKI. If it is sensitive mutation, then one needs to give what we call targeted therapy. That is, in today's time, is Gefitinib, Erlotinib, or Afatinib. That's the best treatment possible for the patient in the first line setting.
Next question is from Rashmi. In India, tumors are mostly diagnosed in advanced stage. How is targeted therapy effective?
So targeted therapy is primarily effective in advanced stage only. Targeted therapy should not be given in early stage lung cancer. So primarily it is used in advanced stage. In India, yes, majority of patients, they are diagnosed in advanced stage. But having said that, in majority of the places in the world, most of the lung cancer, they are diagnosed in advanced stage.
Next question from Ashwin. For EGFR positive patients, what do you prefer? Gefitinib or Erlotinib?
So very good question. There are 3 drugs: Gefitinib, Erlotinib, or Afatinib, and all of them are equally good. Based on patient's profile and based on the side effects, we choose one of them.
Next question. Are RET, MAT or ROS1 mutations being checked in patients newly diagnosed for lung cancer in India?
So we at our center, we definitely do ROS1. MET we definitely do. RET we don't do at this moment because we don't have a very effective treatment for RET. But having said that, I totally concede that this is one of the mutations which can be included in the panel. and we are trying our best to have it in the panel in coming days.
Next question from Sonal. How does low-dose brain radiation help to prevent brain mets for stage 4 non-small cell lung cancer?
So at this moment, unless there is brain mets, role of radiotherapy in non-small cell lung cancer patient in advanced stage is not much, and we don't give it. In small cell lung cancer, we do give it. But in non-small cell lung cancer, to prevent brain mets, as on date, radiotherapy has not been proven to be very effective.
As we take our last question. Question is from Gurpreet. Are there any new drugs that are going to be available soon for stage 4 NSCLC?
There are, in fact, there are many good drugs in pipeline. There are a whole lot of immunotherapy which we are looking forward and looks pretty effective. We are looking forward for immunotherapy in combination with immunotherapy in combination with targeted therapy, and immunotherapy in combination with chemotherapy. There are many drugs in the pipeline at this moment. In fact, there are many very effective treatment for in the patient where they have mutation in second line and subsequent line, where subsequent mutation profiling and choosing a right therapy is being investigated. So yes, we will be seeing in next year or two many more drugs and looks like effective drugs in pipeline. Thank you so much.